So first and foremost, thank you for joining us tonight, everybody. My name is Anna Kilpack, and I'm the Executive Director for NAMI Southwest Iowa. Tonight, this is our NAMI Southwest Iowa C.A.R.E.S series for anyone that hasn't joined us for these. This is the first time that we're doing this virtually. We've done them in person in the past, and we've had such good success with providing programs virtually since we do cover such a large area. We just want this information to be available to everyone and accessible to everyone. So hopefully this is a good choice and will allow us to reach more individuals. So these C.A.R.E.S series really are meant to be an informal presentation or discussion on topics concerning mental health and or disability, and meant to open up the conversations surrounding mental illness and help reduce the stigma. They're held the second Thursday of each month at 6:30 p.m. So again, starting this month, we're virtual. So moving forward, we hope that you'll join us each month. Tonight, and just a little bit about NAMI, if you're not familiar with NAMI, NAMI is the National Alliance on Mental Illness, and it is the nation's largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness. NAMI Southwest Iowa specifically is the local affiliate of NAMI and NAMI Iowa. We serve 9 counties in Southwest Iowa, and we help families and individuals living with mental illness build better lives through advocacy, support, and education. So tonight, we're going to talk about the 2022 legislative session, Iowa legislative session, and recap, and then look ahead to see what we need to be thinking about, advocating for, and looking at moving into the next legislative session. So our expert on the subject tonight is Peggy Huppert. She's the Executive Director for NAMI Iowa. So Peggy, with that, I'll turn it over to you. Thank you.
Great. Thank you, Anna, and thank you for having me. This is the wonder of Zoom, is I'm coming to you from my home in Johnston, and really wonderful to be able to see everybody. So the last legislative session was a pretty good one for mental health. First and foremost was the appropriations bill was passed for health and human services. That's always the big thing, is, the money. And as many of you might know, we have 14 mental health and disability regions in the state of Iowa. And I know that the Southwest region does support the NAMI Southwest affiliate, which is wonderful. And they have been in the past funded entirely through property taxes. There's a mental health levy that was that each county could levy up to a maximum per capita or a maximum dollar amount. And it was very contentious because some counties levy at the maximum, some levied at the minimum, some levied zero, then they would change from year to year. And it was a big source of controversy and tension in a lot of the regions, and also between the regions. Last year, 2 years ago, the legislature passed a law they passed a law eliminating the mental health property tax levy, phasing it out over two years, and replacing that with state funding. And there was a lot of controversy about that because there was a concern that the state would not fulfill its obligation. Property taxes are a pretty reliable source of funding. But the problem was, as I said, it was up to each individual county what to levy. And that was causing a lot of problems within the regions and in between the regions as well. So we favored the idea of switching it to state funding, and also that that change resulted in more accountability from the regions, because we were having a problem with some regions not fulfilling their core requirements. And there was really nothing the state could do about it, because they were funded through property tax dollars. Now, if the state is providing the funding, there's a lot more accountability. And all the regions, as of January 1 of this year, are now performance-based contractors of the state. So they have to do certain things in order to get that money. And provide core services, for example. There are more requirements around reporting, using common language, working across regional lines to make sure that services are provided, and a lot more collaboration and cooperation. So we see that as all good things. The transition was complete as of July 1, and now with this fiscal year that just started, it's completely state funding. So there's no more county property tax money involved. And that's important to know because the regions are still governed by their governing boards, which are made up of supervisors and other people who are appointed. They are now legally responsible for making sure these services are provided. But like I said, it's not their money, it's the state money. So it's important for advocates to understand that in dealing with the regions and holding them accountable for getting these services in place. And it's also important to know that every region is going to get a per capita allocation, based on population, but then there's also going to be a bonus or incentive fund available for regions that are doing a really good job, that are proposing something new or something innovative. That's a pot of money that will be available to all the regions to access. So that's also, and that's in the millions of dollars. So it's not a small sum. So that's also important for people to understand. I'm asked a lot about what I think the results of this is going to be. And I do think that probably we are going to see a reduction in the number of regions because we have some really small regions that have like less than 35,000 in population, and they have no significant providers within the region. So, and no real urban centers. So that makes it difficult for them to fulfill any of the requirements on their own. They are kind of forced to contract with other regions or combine. So I'm not sure, I don't think we really need 14 regions. That they were allowed to form their own regions with their own boundaries to start with. And I think we're going to see that change. It's kind of like, I'll compare it to school district consolidation, which was not forced or required, but it happened naturally because school districts were just, if they were too small to be able to effectively run and compete and meet all the requirements. I think you're going to see the same thing with the regions. We had a summit with the courts in the month of June. We had 3 virtual sessions, and then we had an in-person meeting with a lot of judges and magistrates and court administrators. And we actually talked about that day at that meeting about the possibility of creating the regions to coincide with the court districts. There are 8 districts which have been in place for about 50 years. And the courts, there's a lot of overlap between the work of the courts, the judicial system, and the mental health disability services and programs. So that was an idea that was floated that day. We'll see, but I think that's something we are going to see happen. I am hopeful that we are going to see more of the requirements that were put in place in over the last 4 years. A lot of you know that 4 years ago, the complex needs legislation was passed. That requires the implementation of access centers. There's supposed to be 6 in the state. That no one lives more than 90 minutes away from an access center. There's a lot of access centers east of I-35, but not many west. And that's, to me, that's a real injustice, and that's something that needs to be fixed. The other thing that was required was the doubling of ACT teams, assertive community treatment. That's an evidence-based practice that is community-based. It's a team of providers headed by a psychiatrist that is available for 24/7 response for people who live in the community with serious mental illness, to try to keep them in the community successfully. And although we've had a small increase in the number of ACT teams, it has not doubled. They're supposed to go from 11 to 22 by now, and we only have 13. So that's another thing that needs to, in my opinion, be improved. And then the last thing I'll mention is IRSH homes. And I don't know how many of you have heard of those, but IRSH stands for Intensive Residential. Yeah, I always forget the S, but it's homes. Service homes. Yes, thank you. They are. It's what we describe them as HAB homes on steroids. For those of you who are familiar with HAB homes, they're group homes, but they are designed for people with serious and complex mental health conditions who need oversight and help with medications, behaviors, more than just help with activities of daily living, which is more what HAB homes are about. And we know that there are some people who, they don't need to be institutionalized, but they also are not going to be successful living on their own. And so this is an in-between step, and it's, again, evidence-based. We recommended that be offered 4 years ago. And it is a required core service under Iowa law, but there is not one single IRSH home in the state yet. And that is a big disappointment to me. The real problem is that the regions have not been able to get, well, there were other problems. There were problems with setting a reimbursement rate. There were problems with licensing. There were problems with the MCOs agreeing to pay for Medicaid, but they got all those things ironed out. And now the problem is getting providers to agree to even do it. And they have not been able to get providers persuaded to open one of these IRSH homes yet. So that really is our main legislative agenda moving forward, is to, in the broader sense, working with legislators, with the executive branch, and with the judicial branch, putting pressure on the regions and providers to get these programs and services out and available. I often say it's not like we don't know what we need to have. We do know. We know what works. We know the evidence-based solutions. We just need to get them out. And that of course is for the adult system. We still have a long ways to go with the children's system. And that also is the responsibility of the regions now. So that was passed 3 years ago, instituting that system. And of course it was interrupted by the pandemic, which threw a monkey wrench in a lot of things. But there has been some progress, but we still have a long ways to go with children's services, starting with crisis services, which are, there's no crisis response in Iowa right now designed for kids. There's mobile crisis for adults that is used for kids, but nothing designed for kids. So there's also no, we have access centers for adults, but there's no equivalent for kids. So like a physical location where you could take a child for assessment, for de-escalation, access centers, an adult can stay for up to 5 days to be evaluated and for then to have recommendations for further service. We need to either open those access centers to kids, or we need to establish some new facilities for kids. We don't have that. There's a lot more that we could be doing with prevention, screening, services, and a lot of that could be and should be school-based. And so we're, and I do see a lot of progress with the schools. They are doing much more than they were 5 years ago, I will say that. But they've kind of been forced to because of, well, really, a lot of it is because of the pandemic and the increase in behavioral health issues that we've seen as a result of the pandemic. But those are all things that we get involved with, like I said, in a broader sense, working both legislatively and with the executive branch, with the Department of, now, by the way, as of July 1, it is the Department of Health and Human Services. DHS combined with Iowa Department of Public Health. So they're now known as, just like at the federal level, HHS. I see you applauding, Anna.
Yes, that's been a long time coming.
Yes, and it was controversial, interestingly, mostly on the substance use side.
Yep.
They were governed by IDPH, and they're funded separately at the federal level. And they really did not want to be combined with mental health and with Department of Human Services, but now they are. Now the funding streams are still separate from the federal level, but it's all going to be one department at the state level. And I think that that's good because, as we know, they should not be separate. 70% of all people with a substance use disorder have an underlying mental health condition. We know this. Co-occurring conditions are the rule, not the exception. And they should be treated, and addressed holistically. I challenged the court system on that at our summit. I asked them, why do you have drug court and mental health court? Why are those separated? Well, it's just the way it's always been. Mm-hmm. I said, well, how about we think about doing it differently? Because the majority of people who come before your court are not going to have one problem or the other. They're going to have both. Right. And they should be treated holistically. So anyway, that's why I really want to emphasize today is that I know we think about advocacy more in the legislative realm, and we certainly are very active in the Iowa legislature, but we're also trying to be very active in the executive branch. I have monthly meetings with Director Garcia and Marissa Ianson, who's the head of the Community Mental Health Bureau. I've had a lot of dealings with the Department of Education on school-based. There's an Iowa Best Conference that was held for the first time last year, all about school mental health. that's going to be held again this fall, and we are going to be presenting at it about NAMI ending the silence.
All right.
Yeah. Yeah. We are in regular contact with the Iowa Center for School Mental Health at the University of Iowa. We do work with Iowa Workforce Development, and that was one of the bills that was signed into law this year. It establishes a new mental health practitioner loan repayment program, because we know that workforce is a major challenge. You know we don't have enough of anything in Iowa. We don't have enough psychiatrists. We only have about 120 psychiatrists in the entire state. That's fewer than in most metropolitan areas. In most cities, we have fewer in our entire state. We have only 31 child psychiatrists in the state, and they're just in 3 counties: Johnson, Lynn, and Polk.
Yeah. And mention, what is the median age?
Oh, yeah.
Those 120 psychiatrists.
57.
Yeah.
57 is the median age. So we have an aging population of clinicians. 2/3 of Iowa counties have no mental health practitioners at all. So that is why that telehealth has been a major boon, and it has been a real silver lining of the pandemic. And that was a legislative victory that we had last year. We worked really hard with the Hospital Association, the Medical Society, National Association of Social Workers, and other groups to get that telehealth requirement that clinicians must be reimbursed at the same rate for telehealth appointments as they are for in-office appointments for all behavioral health. And we got that law passed last year, and that has made the difference in maintaining that availability of telehealth in Iowa. And we know that's so important in a rural state because we don't have enough clinicians. And if people have to travel 90 minutes or 2 hours to go, for an appointment, they're just not, either they're not going to do it at all, or they're not going to keep doing it, especially now with the price of gas as it is. So we had a webinar or a Zoom thing in November of 2020 with the University of Iowa about farmer peer support. And we had a farmer from Southeast Iowa participate in that. And he told the story of how he had really been struggling with his mental health for a while. And then the derecho came through and damaged his crops, and he had drought. He had financial struggles, and of course the pandemic, which isolated him and his family even more. And he said, I realized about in July that I was not going to get through the year without some kind of help. So he addressed it with his family doctor, and they determined that the closest therapist to him was about a 90-minute drive. He said, I can't take that kind of time away from the farm every 2 weeks, or certainly not every week, which is what they determined he needed. And his family doctor said, well, do you know about telehealth? And he said, no, what's that? So he explained it, and he helped him get connected with a therapist in Iowa City that he was able to do telehealth visits with from the cab of his tractor. And he said he did it every week, all the way through harvest season. And he said, that is what got me through, was those therapy appointments. And he said, I tell everybody, I talk about it at the cafe, at the co-op, at the, and, it was just so great to hear that because, what a difference that makes, right? When
Yeah.
a farmer is telling fellow farmers that this has been his experience and that it's available and it works. So I'm really proud of NAMI's role in getting that telehealth requirement passed. And we're going to make sure that it stays there because it's really important. And then another bill I wanted to highlight was that passed was they've created a new level of reimbursement under Medicaid for psychiatric intensive care. So what that's going to do is there's 6 or 7 hospitals in the state right now. And one is in Council Bluffs that has the ability to care for patients with complex needs, complex psychiatric needs. I say anybody other than with a garden variety depression, there's supposedly 37 hospitals in Iowa that have psychiatric inpatient units, but most of them don't have the staffing to take anybody at all with any kind of, when I say complex needs, I mean, it's a serious mental health condition along with something else. So that could be a substance use disorder. It could be a history of violence. It could be intellectual or developmental disability. Anything that presents any kind of complexity or challenge or behavioral challenges, most hospitals are not going to admit those patients. And so it's a real problem. That's why we have people sitting in emergency departments for days or sometimes weeks waiting for a placement. So in order to try to address that, the legislature this year passed a law establishing this new level of reimbursement, and that is meant to encourage hospitals that do have that capability to add more beds and also to try to triage people to be able to, and using the firehouse model, which is that there are beds always available, right? We don't just reimburse firefighters for the fires that they put out, right? We have a fire station where they're always there, ready to go out and put out fires and address emergencies. That's what we need more of with behavioral health. We need that firehouse model where there are beds available. Unfortunately, right now, those hospitals like U of I, like Broadlawns, like others, they are constantly full, and so there are never any beds available. Often it's if there are patients in their waiting rooms and a bed becomes open, they go in, but nobody else from any place else is going to be able to get in. So we need to expand that capacity along with the IRISH homes and the ACT teams and the community-based capabilities in order to make sure that people get the help they need when they need it. So I was really glad to see that, and we're going to be monitoring it to see what I don't want is for the hospitals that are already providing that care to just get more money for, what they're already doing. We want to see it act as an incentive to create more beds. But of course, staffing has been a real issue, and almost all of the hospitals are now chronically understaffed, especially nursing. They cannot find nurses. We had 2 psychiatric inpatient facilities open in the last 4 years in Iowa. Clive Behavioral Health here in the metro, they have 100 bed capacity. but they only have 34 beds open because they can't staff them. Eagle View in Bettendorf, Iowa has a 75 bed capacity. They're only operating at about the same level, between 30 and 35 beds, because again, they can't hire the staff. So that to me is a crying shame when we have these state-of-the-art facilities that are sitting there with empty beds because they can't hire enough staff. So that's definitely a workforce issue that we have to address. And I don't know, so far we have not found the solution to that. We're going to have to keep trying. And then the last issue I wanted to bring up is 988. Now, do you all know about 988?
Yes. Yep.
Okay.
We had a couple of radio interviews actually this week about it, and then we released something in our newsletter about it for July. So yeah, we've been talking about it quite a bit.
Well, so have I.
That's wonderful.
Yeah, 988 starts on Saturday across the nation. And Dan Gillison, our national CEO, has called this a once in a generation opportunity to change how we do crisis response. And I absolutely agree with that. I think it's going to be a game changer. Just the idea of having a 3-digit number that people can call and get help immediately is going to make a huge difference. They're estimating that the number of calls, it's to essentially the former National Suicide Prevention Hotline. The number of calls is projected to, at the very least, quadruple, and possibly as much as 10 times the number of calls they're projecting. And calls or texts, either one. And of course, we have had your,
or chat.
Right.
Yep.
So we've had Your Life Iowa here in the state for a few years. And the volume has increased pretty substantially to that. That's operated by 2 organizations, Foundation 2 out of Cedar Rapids and Community out of Iowa City. And they will continue to be the providers for that. I feel pretty good about Iowa's readiness. I think we're in pretty good shape to be able to respond to those calls and texts. But I'll always say it's a 3-legged stool, right? So we have the ability to answer the phone calls. Our standard in Iowa is that 80% of all phone calls and texts will be responded to within 30 seconds by an Iowan. Now, every call and text will be responded to, but it might not be by an Iowan. It might go to a overflow center. But that's the standard that has been set. So we're going to be watching to see if that is met. And then what we know is that if people call a place or text a place and they can talk or have contact with a person who is trained to respond to them, well-trained, which these people are at Foundation 2 and Community, they can handle 90% of the calls and texts right there. That's huge, because those are people who then will not have to go through 911. And it's going to divert a lot of people first responders from having to respond to things that in many cases they are not trained to respond to. So that is huge. The second leg of the stool is the 10% who are going to need some kind of in-person response. And of course, that's mobile crisis response. And that's a little bit more problematic because in Iowa, we actually have 11 counties that don't have it at all right now. And in the rest of the state, it's better in some places than others. I'll just be honest. And so, you know, we're going to have to see how this rolls out and what people are going to say. And we're encouraging people to let us know what experience they have so that we can help track that. And then if we have an appropriate mobile crisis response from trained providers, we know that they can handle 80% out in the field of the calls. So that's huge too, right? Then you're down to just 2 or 3% of people who are going to need to be transported somewhere. And of course, we just talked about how that's a problem here in Iowa because we don't have enough beds. We don't have enough access centers out there. So, but if we can take care of more people through the other two means, then that's going to be reduce the number of people definitely who end up in jail or in the emergency room. And that is our goal. So the state of Iowa has budgeted $3 million for 988 for this fiscal year. And that really is just for the phone and texting part. That's the regions are responsible for the other parts. So we'll see how this is going to stress test the system. And we're going to see how they respond. I just had actually a meeting today with Director Garcia, and we talked about this, and she said we are going to be keeping very close tabs on how this rolls out and where there are gaps and where there are problems. We want to hear about them. So that's a message that we want to help spread. You will start seeing more promotion for 988. They're going to have TV ads, they're going to have radio ads, and lots of different ways of getting that out. Social media, for sure. We're also going to be, and I ask for your help in this. A big issue is how our 911 dispatchers going to warm handoff people who really are more appropriate for 988. If they disclose this is for a psychiatric emergency, then they should be promptly given a warm handoff to 988. And we're going to try to keep tabs on how that's working. Now that's a challenge because 911 is completely done locally. There's no overarching training or accountability or communication across the state for 911 dispatchers. It's all handled by local law enforcement. So I'm going to really encourage all of our NAMI affiliates and all mental health advocates to let us know if it's not working in your area. If 911 dispatchers are not handing those calls off to 988 and mobile crisis response has to go through 911 and it's not working right, we want to know about it because we want to make sure that it does work right. And we want to take full advantage of the opportunity that the establishment of 988 is giving us. Right. So I ask for your help in that. We're also going to make sure that they're fully funded. The 911 is funded by a phone surcharge. Originally, when 911 started in 1968, that was all landlines, of course. Now it's mostly cell phones. But that's how 911, it's billions of dollars. That's how 911 is funded. And we think that that's how 988 should be funded, is through just an extension of that phone's surcharge. And 5 states have passed laws to do that. Iowa has not. They're using a lot of that extra federal COVID money right now to fund it temporarily, but that money is going to run out. And then we're going to have a sustainable source of funding. So that's another thing that's going to be on our legislative agenda is making sure that it's adequately funded. And another thing is, you know, if we can't get data and answers from all the locally controlled 911 local law enforcement, then we might look at having a bill for requiring that they all report how they're doing and what they're doing, so that we can make sure that things are being done properly. So we'll see how that rolls out.
So I have a question on that. So the mobile crisis response, will that be dispatched directly from 988?
That depends. It depends on the region. So like the East Central region, which includes Lynn and Johnson counties and Dubuque County, it's actually the largest population region. They work directly through Foundation 2 on their mobile crisis response. So it's going to just be like all one, very, very smooth, seamless. But in Polk County, all mobile crisis has to go through 911. So if they determine that mobile crisis is required, then 988 is going to have to go back through 911, which is not ideal.
Right.
And you know, we know that a lot of people do not call 911 because they do not want a law enforcement response. And we hear that routinely, especially from people of color, families of color. So if they require mobile crisis response and they have to go back through 911 and it's law enforcement, that could be a problem. So again, that's why you want to keep tabs on it. We want to see how it's working. And if it's a problem and if it's not working, we want to try to fix it.
Yeah, I was just thinking about from the reporting standpoint, you know, it would be nice to know if 988, if the dispatch can come through 988, then obviously the mobile crisis response provider could track that, you know, where is it coming from? But if they all have to go through 911, then that doesn't help us. Yep.
Right. So that's, again, comes down to the, you know, that debate about how much should regions be able to do their own thing and do it their own way versus the uniformity and accountability. And it's really hard for people to, like, they don't know what region they're in, you know, they don't, you know, they don't know.
Well, and I mean, does that need to be a core requirement for the regions?
Well, mobile crisis response is,
right,
but we have one region that still isn't doing it. So,
so yeah, I mean, I just mean, I guess, should that be part of the core requirement, how it's dispatched? You know, just a thought. Yeah, this is really interesting. I applaud you, Peggy, for everything that you do and how involved you are with not just the legislative advocacy, like you said, but also the executive branch and you know, your work directly with DHS and just staying on top of that and keeping a pulse on everything going on and having that input and just representing, you know, I appreciate that. So thank you.
Well, thank you, Anna. It truly is my pleasure. And I'm very proud that NAMI has obtained a seat at the table in a lot of these settings, because they ask us what we think. And so finally, you know, the voice of peers and the voice of family members, the people with lived experience, is being heard.
Absolutely. Absolutely. So yay. Everyone's been pretty quiet. I feel like you've really shared a lot of really good information and we're just kind of all soaking it up. Does anyone have any questions at this point? Anything that you would like Peggy to expand upon, or any direct questions that you have for her.
Well, this is Chris. Hi there. I was glad to hear you talk about 988. That was going to be my question about how the rollout's going and what the big picture is. And I have a simple question. What's a mobile response unit?
So mobile crisis response is when someone, right now it's 911, they call 911 and they say they have behavioral health emergency, whether it's themselves or someone else. A typical thing would be, a parent calls because their teenager or their adult child is in crisis, is perhaps in psychosis, is hallucinating, is hearing voices, or it could be they fear that they've overdosed. They're behaving erratically, and the person doesn't know what to do. So in most areas of the state, they've established a crisis response. Some places it's just law enforcement, hopefully ones who are trained. And there's a 40-hour training called Crisis Intervention Training, CIT, that teaches law enforcement how to de-escalate and how to deal with people who are in a behavioral health crisis. But in more and more places, what we're seeing is a team approach. They just started this in the Polk County Metro, where now they're dispatching a social worker, usually a clinician, who's trained in crisis response to go out with the law enforcement. And they always have that. Now, in Eastern Iowa, there's 7 counties in Eastern Iowa where Foundation 2 is offering non-law enforcement crisis response. And we're seeing that now more and more often across the country, because we know that if people, something that you might want to Google, it's called CAHOOTS. It's a model out of Eugene, Oregon. We had them present at one of our conferences. It's completely non-law enforcement. Crisis response. They've been doing it for 23 years, and they have never had a violent incident with a client.
Can you spell that?
CAHOOTS, CAHOOTS. More and more, the data tells us that this can work. A lot of that is rooted in stigma. It's rooted in the idea that, people with serious mental illness are dangerous, and we have to have a law enforcement officer present. But what we know is that often the uniform and the badge is actually triggering, and it causes more problems than it solves. So that's why I think 988 is I'm so hopeful about it, because I see a lot of movement on the part of law enforcement, and not just law enforcement. I'll tell you, first responders, there's a lot of fire EMT units that are responding to behavioral health crises. It's not, I said, it's not just about rescuing cats out of trees and putting out fires anymore. The majority of fire EMT calls now in a lot of places are for behavioral health crises, and a lot of times they have no training at all. So we need to do better, and I think the movement toward non-law enforcement trained clinicians who are experts in de-escalation and assessment is going to be tremendously helpful in that. What else can I answer?
Everybody jump at once. I know you've got lots of questions. I see Jason sitting back there smiling. I'll put you on the spot. So Peggy, Jason is our new board president,
Oh,
and
great.
he has a real passion for advocacy. So
Awesome.
I know his wheels are turning.
Well, I want to make sure that you all have signed up for our advocacy, be on our grassroots advocacy list. You can do that on our website. I do a weekly update throughout the session that'll keep you up to date on everything that's going on. And I always give action items every week. Encourage you all to, it's right on the homepage of NAMIIowa.org. Sign up for that and encourage others to do that as well. Of course, we have our Day on the Hill every either February or March. We haven't set the date for next year yet. We also let everybody know what legislative forums are happening across the state over the weekend for every week. So you can connect into that as well.
Yep. Sounds great. Thank you.
I'm just curious. What committees do you lobby in the legislature for the most part?
It's mostly human services.
Yeah.
But also it could be appropriations, that's where the money goes through. It could also be, sometimes it's public safety, sometimes it's education. It just depends on the topic.
Gotcha.
But I'd say 80% of the bills that we're following and working on go through human resources. And the chairs of those committees is Ann Meyer from Fort Dodge, is the House Committee Chair. And then Jeff Edler from Marshalltown is the Senate Committee Chair.
What was his name again, did you say?
Senator Jeff Edler. It's EDLER.
Great.
And the other important people are the co-chairs of the HHS Appropriations Subcommittee. That's how the spending gets decided, is through these different subcommittees. And ours falls under the Health and Human Services. And Representative Joel Fry is the House chair for that. He's actually a therapist himself. He's in Centerville. And then the Senate side is Senator Costello. Actually, I think he's from Southwest Iowa. Randy Costello, although there's word that he may be replaced next year. So we're not sure what's going to happen with that.
Yeah, he's not running. Cecil's, Costello, he's not running again, is he?
I don't know.
Yeah, I don't think so. Yeah. Maybe I'm wrong, so.
And again, in my advocacy updates, I always tell you exactly who the important people are to reach out to. We give you the contact information. We try to lay it all out and make it as simple as possible for you to do your outreach. But I also would encourage all of you to, during this, it's campaign year. It's an election year. So a lot of everybody in the House is up for re-election, and half the Senate. So try to attend campaign events, get out and talk to your candidates, ask them where they stand on mental health and what their solutions are and how they think things are working. Let them know that you are a mental health advocate and that you're going to be following what happens. And, we now have a database that shows us, we can track people by their, because we have people's home addresses. So we know what legislative districts everyone is in. And so we can, like if we're trying to reach a particular legislator, we can look up in our database who's in that district. And then we reach out to just those people and we say, okay, we need you to reach out to Representative Fry about this issue. you're one of his constituents. And it's a big deal if a legislator hears from 5 people about a particular issue, and that it's not like a postcard or something that is prepackaged, essentially, you know, that it's actually, you know, a real person saying, I'm a mental health advocate and I care about this and I hope you'll vote this way. That's a big deal. And here's my story about how one person can make a difference. We were struggling with that telehealth bill, and Representative Fry was just trying everything to try to get it through the Senate, because the Senate did not want to pass it. The House had passed it, and they were trying to figure out ways to get the Senate to take it up and pass it. And he needed the backing of his leaders in the House, and he didn't really have it. And so he said, you need to find a way to get Senate, the Speaker of the House, Pat Grassley, more on board on this issue. And so I looked through the list of who do we have in Pat Grassley's district, and I found Joan Becker, who a lot of you know. Joan is a wonderful advocate, and she's spoken at our conference, and she's wonderful. So I called up Joan and I told her what we needed, and I said, I know you're his constituent, and she said, oh yeah, I know the Grassleys very well. I talk to him regularly. I said, well, would you be willing to reach out to Representative Grassley and tell him he needs to be a strong advocate for this? She said, absolutely, I'll do it. She did. And that is what made the difference and got Pat Grassley to go to bat for Joel Fry in the negotiations between the House and the Senate, and ultimately tipped the balance. The governor got involved, and they had a compromise bill, and telehealth was part of it. And I credit that to Joan Becker, because she's the one who reached out and got her legislator, who happened to be the Speaker of the House, but to go to bat. And then he put out a newsletter at the end of the session last year, and he talked about, the whole newsletter was devoted to mental health, about the importance of mental health, and about how he heard from his constituents that this was important, and that he was really proud that the House had gone to bat on behalf of telehealth for behavioral health care. That's the power of one advocate.
Absolutely. And, and that's the power of telling your story, not just reaching out and say you need to support this, but why they need to support it, and be able to tell your story and why it means so much to you. All of us should be ready to tell our story.
And you know that, Anna, you've been to our Day on the Hill.
Absolutely.
And
I just did a CIT training, panel today. So, being able to just go out there and share our experiences and the importance of, learning what you don't know.
The voice of lived experience is extremely important. And we have to make sure that it's heard in every setting possible.
Yep, absolutely. Well, thank you so much, Peggy. We took up your whole hour, but it was very good. It was very informative. Great discussion. Thank you to everybody that came. Are there any last questions before we go? Anything that we didn't get to?
Not so much, excuse me, Jason. I'm a therapist, newly licensed. I started my career as a therapist in April of 2020.
Oh, wow.
Right. So all I knew starting was telehealth. I still see the majority of people through telehealth. Office I'm working at currently is in Council Bluffs, but I'm seeing people in Creston, Corden, Red Oak, places where there might be some but also transportation challenges. And telehealth has really helped bridge that gap. And what I found, a lot of providers don't necessarily like it, but they'll do it. Whereas I love it. I think it's great. I mean, this was my office for, the first 18 months of the career. So thank you for helping to get that to where it stays, and anything I can do to help keep it that way, I will do. But also, as I'm working and talking with a group of social workers and licensed mental health counselors, there's the reimbursement rate with Medicaid. And that hasn't really gone up any in at least 7 years.
So I should have brought that up, Jason. Thank you for raising that. We're going to be getting some information out about this, that HHS is contracting with an organization called Mathematica to do a comprehensive review of reimbursement rates and all the waiver programs. And they're going to be having town halls and opportunities to give feedback all across the state in August, September, and October. And they're all listed on the HHS website. But we're also going to be getting word out about that to people and making sure people are aware of that opportunity to have their voices heard on what they should be looking at in the way of changes for reimbursement levels. We know that they are very uncompetitive for a lot of categories and haven't changed for a lot of years. And it makes it almost impossible for providers to hire staff, but also on the waiver programs. So people with lived experience, personal experience on those things, we really hope that you all turn out and share your experiences and give your opinions.
And you said in the last 7 years they haven't changed. How about since 2004? I mean,
it just depends. Like the PMIC rates, for example, were just raised. So some rates have increased,
right,
but a lot have
not for outpatient mental health.
No, a lot have not.
Yeah,
for a long time.
Exactly. The other thing that is a complaint about the MCOs is the recoupment that they're currently going through, and small agencies being unable to tolerate that kind of behavior from them, which is going to prohibit them from getting any providers.
Sandra, I've heard that so often, and I'll tell you that from my perspective, that's why this new round of competition for the new MCOs is so important. They had the proposals were due May 16th, and they're going to be announced on August 31st. It's Amerigroup is competing with 4 other companies for slots here in Iowa. Iowa Total Care is going to be competing next year because they were later to come into the market. But we have actually been in contact with all of the companies that are in competition, and we actually conducted focus groups for CARESource with people with lived experience, because they wanted to hear, if you could wave a magic wand, how do you want MCOs to do things differently? So I am hopeful that competition will make things better, because I just hear consistently that with the 2 companies that we have now, there are a lot of problems.
A lot of problems.
Yep.
The new companies will be lucky if they get any providers, quite honestly. The way, if you follow any of the Facebook therapist sites, there's a lot of unhappy providers that are at the end of being providers for MCOs.
Well, it's really, really important. NAMI belongs to a coalition called Medicaid Matters. And, you know, Medicaid pays for 2/3 of all behavioral health costs in our state right now. And it's really important to us that we have enough clinicians who will accept Medicaid patients. And that's already a problem. So that's a huge priority for us, is to make that better. I hear you.
Workforce is very, very high on the list of priorities. And, you know, not only attracting new workforce, but we have to maintain what we have. We cannot lose providers. So absolutely.
Yes.
Be a priority. Yeah.
Where are the providers going? What states are they going to?
All of the 6 surrounding states, their rates are higher. So if you lived in Council Bluffs or Omaha or Davenport, you know, easy to get licensed across the state. But Peggy, are you familiar with the Interstate Counseling Compact?
Yeah.
Where does NAMI stand on that, and how do you think the Iowa legislature would take that?
NAMI does not usually get involved in scope of practice or licensing or reimbursement issues, just because it often pits one group against another. So like it might be the ARMPs versus the docs, or this group versus that group. So as a rule, we don't get involved with that, but we sometimes do if it really is clearly about access to care. So, we haven't been asked to jump in on that issue, but, you know, Renee Schulte is our primary lobbyist, and she's a licensed mental health counselor. She's a former legislator, and she's very well versed on all those issues. So that's something that we could certainly consider if it was presented to us.
Thank you.
Okay. Anybody else? Last call. Okay. Thank you all so much. And Peggy, again, thank you for all the hard work you do, not just for sharing it with us tonight. Please don't hesitate to reach out if we can be of assistance. I know you will.
Well, I hope that you all will. You bring a van load or a car load to Day on the Hill next year, and join us and go up to the Capitol. And it's a really cool day because you learn stuff. You get to be with fellow advocates. We feed you. We take you up to the Capitol in a very nice bus. We drop you off right at the front door. You get to go in and talk with your legislators, and then we bring you back to the hotel. And I think it's a really, really great and important day. And to see all those mental health advocates up in the rotunda together, talking to legislators about how mental health is important is just a thing of beauty.
Absolutely. All right. Sounds good. Well, again, thank you. And just want to remind everybody, NAMI Southwest Iowa is your local affiliate here in the 9 counties in Southwest Iowa. So,
and Anna's doing a fantastic job.
Well, we're certainly trying. We've got a great team going here. So I appreciate everything and everyone. But feel free to reach out. Our website is namisouthwestiowa.com. You probably all went there to get registered for tonight. And 712-542-7904 is our phone number. So this recording will be available on our website probably sometime next week. I am headed off for vacation in the morning. So just for a couple days, and then, but yes, so I will get it up next week. And thanks again, everybody. Have a great night.
Okay, bye-bye.